Good morning, everybody, and I appreciate you guys giving up a couple hours of your life to listen in on this. Also, appreciate you guys coming back uh, from our first failed attempt to do this a couple weeks ago. So, this is the third in the set of presentations on Medicare, and it's important enough that it dictates its own presentation. Part D is simply a part of the Medicare jigsaw puzzle components. But for most individuals in the Medicare system, it is the most important part by far. Certainly, the task that it has is the most significant in terms of the cost imposed on individuals to maintain their health or to deal with the conditions that arise as they age. And most of you guys, if you're in Medicare now, quite aware the potential largest cost that you're going to spend every year is on the securing of your prescription medications. The simple point of logic is most likely you guys will not spend every day in hospital, probably not even more than a couple times over a span of years. Most of you will not spend even a couple times a week going in for outpatient services. But very likely, you're going to be taking prescription medications every day, and not just one or two, possibly a half dozen or more. And if you're lucky, the medications you take are all generic, and thus the cost is minimal. If you're less lucky, some or most aren't generic, and the cost for those non-generic drugs has to be factored in as a significant cost of your monthly expenditures. So understanding not only how the Medicare drug coverage works, but how to effectively utilize that to maximize reducing the cost as much as possible is an essential part of understanding how to utilize Medicare most effectively to access the care you need at the lowest possible costs. Also, before I jump off this slide, if you have additional questions after this presentation down the road, the easiest way to get a hold of me is my email address, but there also is our office phone number that you can reach out to us as well. At any point, if a question arises or an issue arises with your navigation with pretty much any aspect of the healthcare system, you're certainly welcome to reach out, pose your question. So start by, where does Part D fit in to the process of the Medicare system? And I showed this schematic. Anybody who attended the second session will be familiar with this one. Individuals in Medicare are going to be either utilizing option 1 or option 2, or the methodology of how their coverage is going to work. So for individuals that are utilizing option 1, they're enrolled in Medicare Part A and Part B, and they're using Part A and Part B as their primary coverage. When you go to the doctor or the hospital or care provider and they say, "What's your insurance?" you say, "It's Medicare." And then most likely someone at that practice will say, "And how are you going to pay the balance?" "I have a Medigap, a supplement." And a combination of Medicare Part A and B and a supplement most likely assure the cost of the care, whether it's inpatient or outpatient, is fully or most fully covered, but not the cost of the prescription medications. So in addition to having Medicare Part A and Part B, and a supplement to pay off most or all of the balance of what Part A and Part B doesn't pick up, you have a fourth component, the Part D, D for drug. And if Part A and Part B and a Medigap do an excellent job of covering the total cost of your in or outpatient care, Part D does at best a mediocre job. It is truly the weak link in this process and even in option two's process. Whereas a effective Medigap can support the entire cost of your health care, pay the entire balance of what A and B doesn't pick up. No Part D is going to guarantee that all of the prescription medications you could take or are taking are going to be totally covered by the Part D plan. Possibly, if the medications are generic and inherently low cost to begin with, their retail is measured in just a couple dollars, possibly the co-payments could be zero. Most likely, the co-payments are going to be of some amount, and as the drugs are more expensive, that cost that you share could represent a quarter or a third of the overall cost. And we could be talking in the hundreds or thousands, possibly even the tens of thousands of dollars per month, depending on the drug, depending on the coverage. If you utilize option two, you're still going to be enrolled in Medicare Part A and Part B. But now, rather than supplementing it with a Medigap, you're replacing it with a Medicare Advantage plan, an HMO or a PPO type product. If you're enrolled in an HMO or a PPO Advantage plan, the expectation is your prescription drug coverage is going to be incorporated into that product, as well as other kinds of coverage that wouldn't be normally under the Medicare umbrella. Things like basic dental, basic vision coverage, non-medical kinds of services like access to health clubs and concierge support services. But the point for this presentation is individuals that are enrolled in Advantage plans, most likely, not all the time, but most likely, have their Part D coverage built in to the Advantage product. And that can be good for a convenience purpose, that one doesn't have to go shopping for the Advantage plan and the Part D and the other stuff. It's all rolled into one. However, it works also that one cannot have a separate Part D coverage in addition to the Advantage plan. That whatever that Part D is being offered by the Advantage plan is the Part D you must take. And if that Part D isn't particularly very good or doesn't particularly cover all your medications, well, tough. If you want that Advantage plan, that's the drug coverage you're going to get with it. And thus, seeking a different drug coverage means seeking a completely different mode of coverage with a different Advantage plan, or trying to go back to option one if you can. So the point is, for today's presentation, Part D is going to be part of whatever option you're going to select, and it's going to be representing a significant part of the makeup of your coverage, and it's going to be essential that you understand how well your particular Part D is going to work as you're going into Medicare or as you're continuing in Medicare, to make sure that you're going to be able to access your medications in the most cost-effective way. Now, the Part D plans have been in existence now for about 15 years. They're the most recent add-on to the Medicare system. And honestly, it wasn't imagined back when Medicare was created that there would be need for drug coverage, because back then in the 1960s, the cost of medications was relatively a marginal expenditure for most individuals. Back then, the wonder drugs were things like penicillin, which could be gotten for just a few dollars a month. Times have changed. Now, there's no mandate that you have to pick up a Part D plan, although there's a penalty if you don't for every month that you could have a Part D in Medicare and choose not to have a Part D and don't have some other kind of comparable coverage. Then you're accumulating a 1% penalty forever. So if you go an entire year, an entire 12-month cycle without Part D coverage, you now have, for the rest of your life, a 12% penalty, 1% for each of the months. And that percentage, easiest way I can explain it is a percentage of the average cost, to be more precise, the mean cost of whatever the premium costs for Part D plans are for that year. So think of all the Part D plans in existence for that particular year, what the midpoint of those premiums would be on the scale of from the cheapest to the most expensive. That represents what your percentage is going to be applied to the cost. So if the mean premium for a Part D plan for this year, and it is about $35, and you've avoided picking up a Part D plan for, let's say, 20 months, your penalty for the rest of your life then is 20% of whatever that mean premium is, or 20% of $35. Added on each month, the actual cost of your premium for Part D. Now, some people, when they envision what that penalty of usually a few dollars, they don't anticipate that the penalty is going to be necessarily the problem. What's more likely the incentive for the individuals to pick a Part D plan, even if they're not taking any medications, or even if the medications they're taking are all generic, all inherently inexpensive. It's the concern that if at some point during the year they're prescribed a new medication that's not generic, and without Part D coverage, they would have to pay the full price. And if the full price is measured in the hundreds or thousands of dollars, it's either dig deep into their resources to pay for it or run the risk of going without it. And Part D plans, if they're obtained separately, can be as low as less than $10 a month in premium. And the coverage isn't that terrible. It's adequate enough to guarantee they've got some safeguard in case they're taking a medication that's not inherently inexpensive. Or if they have an Advantage plan, most likely the Part D is built in anyway, and this is not a concern. But every so often, someone will ask me, well, what if I don't get a Part D plan? It's like, well, if you're willing to bear the risk of paying full price for your medications, just in case, and there's going to be some penalty added on when if you finally get a Part D plan, then you're certainly free to pass on it. Individuals, although not likely, can simply have Medicare Part A and Part B and a Part D plan and go without a supplement or an Advantage plan. It happens from time to time. But most likely, it's going to be a combination of elements that balance off either Medicare A and B or represent a replacement for the A and B coverage. Obviously, all of the Part D plans are offered by private insurance companies. Most of the companies that offer Medigaps and or Advantage plans are also going to offer Part D coverage. And there are some insurance companies that exclusively offer just Part D coverage, certainly designed for enhancing the benefits that you're utilizing. The times you anticipate picking up a Part D plan is when you initially enter Medicare, obviously. During that 7 months around the initial eligibility, you can reach out to the private insurance companies that are offering Part D plans. And the enrollment will take place simultaneously with the creation of your Medicare A and B coverage. It can take place a bit after, as long as it's within the 7-month period and it's within an acceptable enrollment range. Thereafter, each year during October 15th to December 7th annual enrollment period, you get to evaluate whether or not this particular Part D coverage you have is still working and will be still effective in the upcoming year. And you can continue with it, let it roll over and stay in effect for the upcoming year. Or if during the October 15th to December 7th enrollment period you change, the new plan goes into effect the following January 1st and stays in effect for the balance of the year. Sometimes, though, when certain situations occur, you're allowed to enroll outside the normal annual enrollment period. Some examples of special situations. If you move, and by moving, you move out of the coverage area of that Part D, or if your Part D is attached to an Advantage plan, you move out of the coverage area of your Advantage plan. Lose the coverage is a triggering event, which gives you the right out of enrollment season to pick a new Part D plan. If you become eligible for certain kinds of additional benefits, like PACE, or extra help, or just inherently Medicaid, this gives you a special enrollment period tied to when the triggering of that benefit goes into effect. Or in reverse, if you lose one of those benefits, this also generates an opportunity to select a new, or if you've not selected one up to this point, an initial Part D plan. And if an individual has a Part D plan, and in the course of the year, they're prescribed a medication that particular Part D plan that they currently have doesn't cover that medication, and then the individual beneficiary is entitled to contact the Part D plan, point out that without any pre-recognition or pre-indication, they're now assigned a medication that's not included on the Part D plan's formulary. And the current Part D plan has either the right of refusal to cover that drug, which certainly it's not on their formulary, they can do that, but that then also gives the beneficiary an immediate right to disenroll from that product, even though it's not during the enrollment season, and select a new Part D that presumably would cover that new prescription medication. But keep in mind, they can't automatically disenroll. It doesn't automatically cover or create a triggering event. The triggering event is the refusal of their current Part D coverage to cover a newly prescribed drug that was completely out of the blue as far as the anticipation. The existing Part D will always get first crack at deciding whether they want to cover it or not. And I can tell you, most of the times, your current Part D coverage will likely cover, although most of the time that coverage level is not going to be a very desirable one. You're going to be likely left with one of the highest tiers in terms of pay sharing. So any of these circumstances could allow a swap. But the goal is when you're initially selecting Part D coverage and during the annual enrollment season is to be careful and select in looking at the Part D coverage that you're anticipating in light of the situations that may be arising for the upcoming year, and looking for one that most likely is going to anticipate the various events that could occur. Regardless of whether your Part D is a standalone that you get with Medicare A and B and a Medigap, or it's built into your Advantage plan, the Part D is going to arrange the drugs that it covers in its formulary based on therapeutic categories. So imagine that there are dozens of categories of how medications are going to be utilized for the conditions you have, the diseases that you have, or that you want to prevent. And those categories are going to be mandated by the Medicare system, by the Centers for Medicare and Medicaid Services, as requiring each Part D plan to cover a certain number of drugs in each of the therapeutic categories. So initially, all Part D plans must cover just inherently a certain general number of drugs. And then those numbers of drugs have to satisfy each of the therapeutic categories' minimum number of drugs. But no Part D plan is going to cover every possible permutation of drug coverage available. No Part D plan is going to be totally, truly comprehensive. There's going to be some gaps in its formulary coverage. And it is essential, especially if you're taking medications that are not all generic, to anticipate every year reviewing that plan. Even if the plan currently covers all your medications, doesn't mean it's going to for the following year. And unless you're prepared to pay full price for a medication because you discovered too late that that plan doesn't cover, and then every year you're going to do a review of your plan in light with the drugs you're taking or anticipating taking for the upcoming year to see if it's still going to function effectively. Not only does every Part D plan have to cover a certain number of drugs in a certain therapeutic category array, but all Part D plans are then going to assign all of the drugs that they cover to various cost-sharing tiers. Now, this is an example of what a very basic Part D plan tier level is going to look like. And at least there's going to be 4 levels. But also fairly common, there can be as many as 6 or 7 or more tier levels. So I'm going to give you a general idea of what to anticipate. So all Part D plans, no matter how many tier levels they're going to have, will have at least one generic level. This is the level at which the either least expensive generics or all of the generics in this particular plan are going to be cost shared. And that's obviously going to be the lowest copayment. Typically, if there's only one generic level, it's about a $2 or $3 a month. If there's 2 levels of generic coverage, the first level, the cheapest generic medications, are going to have typically a cost share of 0. The drugs are free, but that's because those drugs have a retail cost of less than $5, usually even less than $2. And if there's a second generic level, then the cost sharing will be $3 or $4. But again, those are the slightly more expensive generics. Regardless of whether the Part D plan has just one generic tier level or 2 generic tier levels, there's going to be certainly 2 at least non-generic tier levels. So there's going to be what's referred to as a preferred non-generic or preferred brand name level. Now, these are the non-generics that the plan would by its term, wish or prefer that you take rather than the more expensive alternatives. And in this preferred brand category, there is at least one or more from each of the therapeutic categories, so that there is an expectation that one could, in tandem with their doctor prescribing it, obtain a medication that could deal with most likely the condition they're dealing with at a lower cost than some of the other medications in that therapeutic category. Now, not all the time. Sometimes there's not going to be a relatively low cost brand name option. But when that is, it's certainly going to be in the preferred category. And the cost sharing for preferred category is going to be something like $25 to $45 for the preferred brand. There's going to be another level, the non-preferred. It's going to have a cost sharing probably in the close to or over $100 a month cost sharing for the beneficiary. These drugs are not going to be measured necessarily in the hundreds of dollars, but most likely in the high hundreds or thousands of dollars for a 30-day supply. And the cost share should be expected to be somewhere just below or just above about $100 to secure a 30-day supply. And finally, there's going to be at least one tier level for the drugs that are so inherently expensive that are not measured even in the hundreds of dollars retail for a 30-day supply, but in the thousands or even tens of thousands of dollars to secure a 30-day supply. These are the specialty categories. And unlike the previous tiers, which measure cost sharing in actual dollars, your co-payment is $5 or $45 or $150. In this case, the co-payment is a percentage of the retail cost. So at this strata, the plan is not even going to commit to a specific dollar amount that's going to be your responsibility, and thus the balance is their responsibility. The plan is going to say whatever that drug is, because that drug could be thousands of dollars, we'll pay 65% and you'll pay 35% of the cost. We'll pay 75%, you'll pay 25%. Rarely will it be more than 75%. In fact, most of the time it won't even be 75, 25%. It'll more likely be a 65-35 split, and 35% of thousands or tens of thousands of dollars is going to have an initial sticker shock for those costs. But if it's any consolation, it's only going to be likely for a single month, in which case the individual is going to be straddling and plummeting into the donut hole. Which brings me to the next point. Just as all Part D plans, whether they're a standalone Part D or incorporated into an Advantage plan, organize the drugs in their plan in terms of therapeutic categories and in terms of cost-sharing tiers, all Part D plans are going to function in this following manner. At the beginning of the year, all Part D plans, if they have a deductible, are going to require the beneficiary meet that deductible before the plan starts cost sharing. Now, if this was 10 years ago, I'd say occasionally you may find there's a Part D plan that has a deductible that you have to meet first. It's quite the reverse now. It's more common that the plans you're going to have will have a deductible. In fact, fewer and fewer plans initial the beginning of the year with a cost sharing right off the bat. Most likely, there's going to be some amount anywhere from $100 up to the maximum deductible allowable for that year. And currently, that's $480. So if you have a plan, and we'll use the typical low premium plan that imposes the full deductible requirement, you're going to have to pay dollar for dollar the cost of your medications until you finally paid off the $480. Only then will the plan kick in and start paying whatever percentage it's promised to pay for that particular medication. Now, one good bit of news. If the medication is generic, typically that $480 or whatever the deductible is will not be applied to it. That there will be a promise by the Part D plan that you can obtain your generic medications at a discount right from the beginning, and that only the non-generic medications will be subject to meeting the $480 or whatever dollar deductible before the plan will kick in and start paying its share. So once you've met the deductible, or if the plan doesn't have a deductible right from the beginning of the year, then the plan begins splitting the cost of those medications. Typically, this isn't absolute, but this is a good indicator of what the share cost would be. The plan will pay 75%, you'll pay 25%. For some lower cost medications, the plan's percentage is usually a bit higher, 80, 85%. And in some cases, especially for the very cheap generics, the plan share could be 100% and you pay nothing. But realistically and on average, the cost that you're going to pay for the medications after you've met the deductible, or if there's no deductible, it's going to be 25% of the retail cost of the medication. Until what you've spent and the plan has spent for you to secure your medications, until the total spending to secure the medications reaches a certain number. That certain number for this year is $4,430. You're now at the threshold of the coverage gap, the donut hole. So, first step, am I going to secure this drug with any kind of cost splitting? Not until you've met the deductible. I've met my deductible now. Can I anticipate the plan is going to cover some costs? Sure. Probably somewhere in the neighborhood of 75%. But until you and the plan have purchased $4,430 worth of medications. The easiest way I can explain, how do I know I'm hitting the donut hole? Look at the retail cost of the medications under that particular plan. When the retail cost reaches $4,430 over the course of the purchases you make, you have now reached the initial coverage limit, the threshold for the donut hole. Once you've passed the initial coverage limit, you're in the coverage gap. When that occurs, the insurance company is done helping you with the cost of the medication. Now, in the bad old days, that meant that you had to pay literally the full price, the full retail of the cost, till you bought your way out of the donut hole. Currently, thanks to the Affordable Care Act, back in 2010, Affordable Care Act, better known as Obamacare, I guess now Biden Care, incrementally worked into the Medicare system as per the Affordable Care Act was the federal government assisting individuals when they went into the donut hole. Now, it didn't start at a 75-25 split, but gradually over the course of 2010 up to about 3 or 4 years ago, it reached a point where for individuals that are in the donut hole, generic and non-generic medications are covered 75% by the federal government, 25% by the beneficiary. So pretty much, although not absolutely, on par with what they were paying before they went into the donut hole, which compels some people to believe and some pundits to indicate, oh, they've done away with the donut hole. No, they didn't do away with it. They simply shifted the economic responsibility from the insurance company to the federal government. And just so you know also that regardless of whatever the plan promised in its cost splitting, 80-20, 100-0, once you're in the donut hole, it's an absolute 75-25 split. So some people will find, wow, this actually is beneficial for me being in the donut hole, because before the donut hole, we were splitting 65-35. Now it's 75-20. I'm actually paying less for the drug in the donut hole. And some people will say, oh, now I have to pay 25%, where you were paying 0 or something less than 25%. So prior to the donut hole, it's whatever the plan says it's going to help you out with the cost of the drug. In the donut hole, the federal assistance is literally a 75-25 split. And that assistance is for anyone in the donut hole, regardless of how wealthy or poor they are. They have an expectation that they will have a 75% assistance from the federal government towards getting them out of the donut hole. So how does one finally buy their way out of the donut hole? Out of their own pocket. But they also get to count what the federal government is spending on them. They just can't count how much the insurance company has spent up to this point. But once they're in the donut hole, the accumulation of whatever they've spent up to this point and whatever the federal government has assisted up to this point gets counted towards reaching the out-of-pocket limit, which is currently $7,050. So right from the beginning of the year, when you're paying your deductible and you're paying your 25%, and when you're in the coverage gap, the donut hole, the portion you're paying, all of that gets added up to see when you hit that out-of-pocket limit. And in addition, whatever the federal government is putting towards helping you get your medications, that goes towards the $7,050. Once that's finally reached, the insurance company is required to come back online. Federal government is done now for the year. And the insurance company is now required again to start assisting with the coverage, and their required assistance is now 95% of the cost of the medication. And your requirement is now only 5%. But to get to that point, you have to spend out of your own pocket and with the help of the federal government that $7,050 out-of-pocket limit for the current year. Now, every year, the initial coverage limit goes up a bit, but also the out-of-pocket limit goes up a bit. And every year, very likely, the amount of a maximum deductible goes up a bit. But for as long as the Part D plans have been in existence, this has been the model. Meeting a deductible if there is one, cost sharing between the plan and the beneficiary, going into the coverage gap, and the insurance company being off the hook for that period, and then the insurance company coming back online and being required to pay a large percentage of the cost of the meds till you get to the end of the year, and then the process resets itself for the new year. Now, what I'm showing you is an example. This is a real patient. Obviously, names are redacted to protect the privacy of the individual. But this is someone who's recently got into their Part D coverage, and this is representative of what a typical high utilization looks like, not just in terms of the medications this person's taking, but also giving you an idea of what the kinds of costs. And warning, what you perceive as high-end costs isn't even remotely close to what the true high-end costs of medications are. But this is a good example of what a typical high utilization looks like. And just to give you an example of what the cost of the medications and the functionality of the coverage throughout the year. So this person is certainly diabetic. This person also is suffering from high blood pressure and the impacts of prolonged high blood pressure. This person also has gout and GERD, and just the kinds of things that are reflective about someone who hasn't taken very good care of themselves, or just someone that's subject to the process of aging. So, and I've categorized them by color coding the different drugs for the different conditions. And this first column is the retail cost. This is what it would cost this individual if he went into the pharmacy and said, look, just I'm not going to give you my Part D card, or I don't have a Part D card, just give me the medication. The total cost, the bottom of the first column, represents what this person would have to pay if he purchased all of those medications without any assistance from Part D coverage, nearly $2,900. Now, most of the medications, for example, the simvastatin or the amlodipine, that's clearly representing a low-end retail cost. And you could probably afford to purchase them without any help, but certainly at least for the medications, the ones that are highlighted in blue, are going to represent a significant cost for which there's clearly a motivation to get Part D coverage. The Trulicity and Lyrica for his diabetes, the Xarelto as a blood thinner, and the Colchris to deal with the pain from his gout. Those things represent the significant part of that $2,900. And when you take a look at the next column, this is the column of what he would have to pay before he paid off his deductible. And you'll notice this plan, even with the relatively higher premium, imposes a deductible. Now, also, I pointed out that certain of these medications are generic, the metformin, for example, the amlodipine, for example, and the copayment or the generics is the Humulin? No, but there's a promise that was made to help individuals access insulin medication for as low cost as possible. That was a promise made a few years ago, and this plan is certainly adhering to it, that even though it's technically not a generic drug, they're allowing one to access it at a generic cost level. But the other ones, the metformin, the amlodipine, the benazepril, and so on, these are all representing a generic tier level and thus a $4 cost share. And notice, even before you pay off the deductible, you're securing these drugs at the generic tier level. However, the 1, 2, 3, 4 medications that are clearly not generic require a meeting the full deductible before. And this arithmetic represents the necessity of meeting the deductible plus the paying for the generics. Once you've essentially paid in the second month about $500, you secured your medications and you've effectively paid off the deductible. In the third month, or once you've paid off the deductible, then again, the generics are still going to continue to be $4. And the 4 non-generics that were subject to meeting the deductible now drop to a preferred non-generic level, $42. And thus, once you've gone from the full retail to paying off the deductible and now getting your drugs at either the generic cost or the preferred non-generic cost, the total cost is only $124. Except that value is going to be for 1 month only. So the first month, you're going to secure your drugs for at least $516, certainly not the retail. And the second month, definitely you're going to secure those drugs for only $124. But thereafter, the third month and following, you'll be looking at the donut hole. How do you know? Remember I said, how do you know when you've reached that magic number of the $4,300 and so dollars? Take a look at the retail of the drugs. The retail is the determinant of when you're going to reach that $4,000 number. $2,800 for a month's purchase. By the time you've gone into your second month, you've now met and exceeded the threshold for going into the coverage gap. Some of these medications you'll be able to secure at the $4 or the $42 in the second month, but at some point in the second month of purchase, you'll have passed through paying off your deductible. You'll have passed through the cost sharing that the plan promises prior to the donut hole, and you're in the donut hole. And when you're in the donut hole, the metric changes from it's now an absolute 75-25 split. So by the time you're in the third month, the government is paying 75% of this cost, you're paying 25%. The government is paying 75% of this cost, you're paying 25%, and so on. And in some cases, the 75-25 split is better than what the plan has promised. In some cases, it's not. For example, with a Humulin, whereas you would have only paid $4 prior to the donut hole, now with the help of the government, in an absolute 75-25 split, you're paying a bit more. In this case, I'm paying definitely a bit more because it's no longer a guaranteed $42. It's a 75-25 split. And now instead of $124 to secure the drugs, the splitting of the cost evenly for all the drugs of 75-25 requires that you're going to pay $718 to secure the drugs for that particular month. And every month until you have reached the point where you have bought your way out of the donut hole, which is going to be most likely the fourth, probably not the fifth or sixth month, when you have finally, in tandem with what the federal government is helping, reached the $7,050 threshold. At that point, the federal government drops off. It's no longer a 75-25% split absolutely. And online comes the insurance company again, and they're going to split the cost 95-5, except if 5% of the cost of the drug is less than $3.95, then the beneficiary has to pay at least $3.95. So the beneficiary pays either $3.95 at least, or 5% of whatever the cost of the medication is. So anything that you're looking at generic, you can bet you're paying just shy of $4. The four drugs that you're not are the ones where 5% would represent a bit more or substantially more than the $3.95. And now this calculated cost for approximately half the year is going to be $173.63. So in the first month, until the deductible is met, until that $480 has to be spent, the individual is going to probably pay in the neighborhood of $500 to $600 to secure these medications, depending on which medication he purchases first, which ones he purchases later. Probably the better part of the second month, he's going to get the value of the full maximum coverage the plan offers, but not quite, because at some point, again, depending on which med he purchases at the beginning and which meds he purchases near the end of the month, at some point in that second month, he's going to reach the coverage gap, a combination of the first month's retail and part of the second month's that reaches about $4,300. And now, or at least 2 or 3 months, the cost of securing those medications are going to be about $700 until finally he buys himself out of the donut hole And for the balance of the year, he's paying about $173 to secure these meds. That's actually pretty good. And considering the number of meds he's taking and considering the priciness of at least 3 or 4 of those meds, he's going to be shelling out somewhere in the neighborhood of about $2,000 to $3,000 for the year to secure his meds. But I'm going to show you a worse example. This represents the kinds of medications that are on the high end of things. And I'm going to explain a trend that's been occurring over the past decade and something hopefully you'll never have to deal with. But if you do, you have to understand, because this could be an economic devastator. I'm showing you 3 medications that are oral chemotherapy: Cicadia, Xtandi, and Lenvima. Now, to show you the true impact of these meds, it's not bad enough that the retail, or the least expensive of these 3, is about $8,000. That's for a month's supply. And for the Lenvima, one of the more expensive medications, about $21,000 for a 30-day supply. A decade ago, if the doctor had explained to you that your test came back and you were diagnosed with cancer, and the doctor would have said, we want to start an aggressive chemo regimen, like as soon as possible. We're going to do a combination of chemo and therapy. We'll take as much of the tumor out as possible and then continue to see how the therapies are progressing. And you would say, now, how much is this going to cost? And assuming in this hypothetical, the doc has a pretty good idea of how the Medicare system works, she would say to you, well, what's your coverage? And you would say, I have Medicare A and B, and I have a supplement, a Medigap. And she would say, here's the good news. You owe nothing or hardly anything. Depends on what level of Medigap coverage you have. It's the best. It's an F level. Then you owe nothing. Medicare Part B will cover 80% of the cost of your chemotherapy, 80% of the cost of your radiation, 80% of the cost of your diagnostics, and your F level Medigap will cover the other 20% entirely. Or, well, I have a G, okay? There'll be a deductible of a couple $100 and then the same thing. I don't have a Medigap, I have an Advantage plan. All right, then the Advantage plan will cover 80% and you'll cover the 20% until you reach the Advantage plan's out-of-pocket max. So you'll owe about $8,000. Not as good as the Medigap, but at least there's a foreseeable cap to it. That was 10 years ago. That was 5 years ago. What's the new norm? The doctor comes in and says, I have some bad news. Your diagnostics came back and it shows a malignancy. But here's the good news, if you can see it this way. There's a medication that is showing really good results. And I have to come in for a regular infusion. No. The additional good news is it's orally administered. I'm going to write you out a prescription. Here, take this to the pharmacy. I'm getting you started. And you show up at the pharmacy. And you say, here we go. And the pharmacist says, we don't have the medication on hand, but if you come back in 24 hours or a couple of days, we'll have that for you. You show back up. And you talk to your cousin who went through the cancer treatment a decade ago and says, you know, at least the good news is it doesn't cost anything. And so you're at least anticipating that's a bit of good news. And when the pharmacist comes out with your medication and says, that'll be $15,000. So Whoa, wait, no, hold on. Here's my Medigap. It's like, doesn't work. It's like, well, but no, doesn't work. It worked when you got it done at the doctor's office. It worked when you got it done as an infusion, as an outpatient service. You're getting your drug now at a pharmacy, orally administered. Pop it in your mouth and give me 15,000 for it. This was not a coincidence or just a anomaly of the development of how the medications. This was planned and charted and incentivized by the Medicare system. The dates that I have for each of these drugs is when the drug was introduced for utilization, all kind of clustered in the same period. Around the turn of the millennium, the 1990s to the 2000s, pretty much any high-end medication was administered only one way, infusion or injection. They were administered at a doctor's office for fear of some type of bad reaction, an anaphylactic shock, for example. They were monitored. But because they were done in a doctor's office, because they were administered under the supervision of a physician or a nurse practitioner or a specialist, this was considered an outpatient service. And Medicare Part B for basketball, covered 80%, or your private insurance, HMO or PPO, was required to treat it as an outpatient service. And both Medicare and the private insurance chafed at the idea that they were spending a significant amount of the cost for this level of care. And even with an Advantage plan, once you met your out-of-pocket max of $6,000, $7,000, $8,000, they were obliged to pick up the balance of the cost fully, entirely. And then the idea, if we can shift the modality of administering this medication, if we can persuade, compel, bludgeon the manufacturers, and you think, oh, how would they? Here's how they. Medicare tells the manufacturers of the medication, look, you're about to engage in billions of dollars in research and development for a medication that will make you a lot of money when it's released in the cutting edge, but we're going to prevent anyone from having access to it. All the investment goes for naught when we deny the individual access to the medication because there's another medication that they could take orally. So be on alert, manufacturers of the medications. The manufacturer that comes up with the way it can be administered orally, thus we can shift the responsibility to Part D and most of the economic responsibility to the patient, wins. That's the drug we're going to be preferring. That's the drug we're going to be allowing. And it goes head to head with the other drugs. Guess which ones don't get accepted? Guess which ones we deny? Guess which ones are at the bottom of the list of the ones you get to use? Are you sure you guys want to take that risk? And over again, the manufacturers said, we get the message. To make it even more imperative, the promise of the help for Medicare, the unsaid thing, will help fast track the oral medications to get them on market faster. It is not because these medications are necessarily better orally administered, certainly convenient to some degree, and it's not because there's a desire to make them more convenient, make them more practical. In fact, some of these medications probably should still be supervised. Certainly the ones that are administered not by oral format, but have to be injected by the patient, either using an injector pen or pre-filled syringe. And just so you understand, it's not the exclusive realm of chemo treatment for cancer. MS patients went from an exclusively administered medication in a doctor's office or a clinic, and a typical example of that 20 years ago was Tysabri. In fact, Tysabri was the tipping point for the Medicare system. Tysabri still only, could be administered in an injection, in an infusion, in a doctor's office because of the risk of side effects, typically anaphylactic shock. And because the only way that it was administered was in a doctor's office or in a clinic under supervision, it was an outpatient, and Medicare was obliged to pick up 80%, and an individual with the Medigap didn't have to worry about the cost. And Medicare was looking really hard for the manufacturers to come up with an alternative, and they did. They came up with a bunch of alternatives, starting just at the turn of the century. Rebif and Havonex, two good examples, intentionally designed as a counteract to medications like Tysabri. These medications now could be created with the expectation that one would go to a pharmacy with the doctor's prescription, pick them up, even though they're not orally administered, and self-administer them in a syringe or an injector kit. And the cost of those medications, the least expensive in this listing, just over $7,000 for a 30-day supply. And Plegridy and many of the other medications that are utilized for these high-end conditions that are now self-administered are in the more than $10,000 for a 30-day supply. And what does that look like when you obtain, let's say, the Plegridy, for example? Well, you're not truly going to spend $14,800 every month, because here's what's going to happen. The first month, and again, I'm assigning this to a Part D plan that has a nearly $100 a month premium, and the good news, there's no deductible. So we'll say we'll eliminate the requirement to meet the deductible in that initial month, but it doesn't really matter. Even if there was a deductible, within the first month of the purchase, one would hit that $480 amount, incorporated into that $14,873. Whatever the cost splitting, whatever the share that the plan is going to pay and you're going to pay, that's also incorporated into the first purchase, the first month. You're going to hit the donut hole in the first month. A monthly cost of $14,000, almost $15,000, is going to certainly exceed the threshold for going to the donut hole. You're in the donut hole in the first month. And with the help of the federal government, you're going to pay the amount necessary to buy your way out of the donut hole in the first month. And even in the first month, you're looking at a portion of the cost of the Plegridy as covered in the catastrophic cost share between the insurance company and you. 95-5 split. You've passed through every level of coverage cost sharing in the plan in just the first month. And thereafter, the second and every other month till you reach the end of the year, your cost share is 5% of the retail, and 5% of $14,873 is $743.73. So the first month is going to be ouch, and the accumulation of all the levels necessary to get you through to the catastrophic, it's going to be an economic burden on you, not counting the premium, of about $3,200. That's your monthly cost in the first month to get you through each stage, including part of catastrophic coverage, even in that first month. And thereafter, you're four square in catastrophic coverage. You're paying 5% of the retail for month 2 through 12. But you're dropping about $7,000 in month 2 through 12. And the $3,000 in the first month, you're dropping $10,000 for the year to secure that drug. Here, it would be something more like $5,000 to secure Avonex. But for Lenvima, it's going to be something like $15,000 for the year. And keep in mind, if any one of these medications had to be administered the way it would normally have been done a decade or so ago, or if you're taking a medication currently administered only in an infusion format that has to be done at a doctor's office or a clinic, it would cost you, if you had a Medigap, essentially nothing. Even if you had an Advantage plan, it would cost you significantly less than if you had to secure it under a Part D. And this is the trend, guys. If you're lucky, you're not going to be faced with dealing with a costly, continuous, pernicious disease that is going to cost not hundreds of dollars, but thousands of dollars. And in many of these cases, especially for MS, this is a forever proposition. This is on top of all the other expenditures for your health care. For the Plegridy, you're spending over $10,000 a year. For the Avonex, you're spending over $5,000 a year to secure the medication necessary for you to function. And this is just two kinds of conditions or diseases that we're dealing with. There are dozens of other situations that compel the access to medications, which have now been shifted to oral administration or self-injected administering of the drugs that pass the burden of the cost to the patient significantly. And as long as Part D functions the way it does, and as long as the cost of the medications are not controlled other than the bargaining between the manufacturer and the insurance companies, and there's no intermediary that controls the price cost significantly, then this is what you have to look forward to. So on the one hand, you have someone like that who, yeah, there's 4 drugs that are relatively significant in cost. And likely this is an individual that's going to be paying a couple or $3,000 in the course of the year for all of these medications because a significant number of them are relatively inexpensive. And if you remove the 4 very expensive drugs, the costs are manageable. That would be a lucky person. The unlucky person is someone who's diagnosed with cancer or MS or a condition where they're utilizing immunosuppressants or other kinds of medications that are designed to deal with a chronic, pernicious, expensive, and most of the cost is coming ultimately out of the pocket of the individual. Here's something else you need to be cognizant of. So even if you say, okay, look, I'm going to suck it up. I know we have to deal with my spouse's MS. It was for me, you know what? I don't care. But I'll be damned if I give up on my spouse. Whatever it takes, whatever the cost. Oh, were it even that simple. Because here's what's going to happen next. So you show up at the pharmacy and you say, all right, here's the prescription, doc. and I brought a few $1,000s with me. And the pharmacist says, I got some more bad news for you. This particular medication requires a prior authorization. It's like, what the hell's a prior authorization? Well, see, before I can give you this prescription, unless you're prepared to pay full price for it, I mean the $14,000 or the $8,000 or the $7,000, we have to have a verification from the physician. Isn't that what the prescription is? It's him saying, I need this med, and legitimately, legally. Yeah, that's to fulfill state law requirement and his practice requirement. But that's not what I'm talking about, says the pharmacist. This is about whether or not your insurance company is going to pay for it. Well, you know what? I would have preferred that it got paid for as an outpatient service, but I guess we're not going to do that. No, it gets worse, the pharmacist said. Even the insurance company, remember, the insurance company still has to pay some portion of this, and they don't want to pay any on this. So first, Medicare persuades, entices, bludgeons the manufacturers to come up with a alternative that's awfully expensive. And then the patient has to show up at the pharmacy to suck up a huge part of the cost, only to be told that the other entity that's going to be sucking up some of the cost, the insurance company, doesn't want to suck up any of the cost, or certainly not on that medication. And so here's what to expect. Very likely, for expensive medications, a Part D plan is going to require a prior authorization at least. And what that means is a doctor has to tell the insurance company why that medication is the medication the patient should be taking, as compared, remember the therapeutic categories? There's at least another half dozen to a dozen other medications in that therapeutic category that are much cheaper. And wouldn't you rather have a much cheaper medication, doc? Wouldn't I? No. The reason they're cheaper is because they don't work as well. Maybe 30 or 40 or 50 years ago, when it was the best we had, it was the best we had. But they're not that good. They're still there because they represent the therapeutic category and because we need ballast. But I would not imagine utilizing that medication compared to what we could have. The one I'm recommending, the one I'm prescribing, it's on the cutting edge of dealing with this condition, and it will deal with it the most effectively. That's why it's that expensive, because the manufacturer knows it's on the cutting edge. And as a result, the insurance company says, no, we'd rather you take the other one. In fact, we're going to make the doctor go through hoops to allow us to pay for the cost, even though you're going to be paying a significant part of that cost out of your pocket. We'd rather that you pay just a little bit and that we don't have to pay that much either. Doesn't mean the drug's going to be that effective or as effective, but that's how we're going to do it. Now, I can tell you, pretty much anytime the doctor challenges the prior authorization requirement, the insurance company is going to fold and say, it's all we wanted. We just wanted your prior authorization, doc. What this is really about is the social conditioning of the doctor to say, doc, every time you write a prescription for this medication, I guarantee you're going to get prior authorization requirement. And not just our insurance company, but every other insurance company is going to make you jump through the hoop of writing up a multi-page presentation of why this drug is the best and submit it. Get used to it. Get used to it every month. Get used to it for every patient you have. And if we really want to put you up against it, we'll take you one step further. We'll require step therapy. That means that if you want to authorize this drug and you want us to cover it, before that, you have to try every other medication in this therapeutic category before we'll authorize this one. So get started. And will they cave to a challenge? You bet. Will they have to go through every single medication? Nope. But they will require the physician to set up the argument why this patient should not have to go through step therapy, and the time and the effort that it takes to create the argument, to present it for this particular patient based on this particular patient's set of circumstances. And you can't just write up a boilerplate that applies to any condition that would come down the pike. I'll just send my copy. Nope. It has to be contoured to that person specifically. Why? Because we want you to work at it. Why? Because we believe there is a percentage of physicians, if confronted with this effort, will say, you know what, screw it. I'm going to go with the lesser cost, the lesser challenged, the more expeditious version. Not all doctors will do that, but enough doctors will. Enough doctors will choose the path of least resistance. And the prescription medication that you're being assigned, you may not know this is not as good as others, as effective. That the reason this drug is prescribed is because it's the easiest one to pass through the process. The system is now compelled to look for the least expensive alternative. And that's not necessarily bad from an economic standpoint, but in terms of the efficacy of the therapy, many individuals may be getting less than the best. They may be getting less than the best because from the very beginning, there's an understanding that they couldn't afford the cost of the medication. That it's not a question of going through a step therapy or a prior authorization. It's full realization that if that particular medication, the high-end medication in terms of cost, were prescribed, the patient could never afford to get it. They could never afford to pass through the donut hole. They couldn't even afford the 5% once they pass through the donut hole. They're going to get the least expensive medication they can. Or that the alternative end of the spectrum, that individuals that, even if they're prepared to spend, capable of spending a higher portion of the cost, will never even have the drug prescribed because the doctors are not going to go through a process that they know they're going to have to. Prior authorization or step therapy. So understand that when you're looking at your coverage, look for the asterisks. Look for the notations that point out this particular medication, although it's covered, is going to require a prior authorization or a step therapy. It's not enough just to know the drug is covered, not enough to know how much it's going to be covered for. It's anticipating there's going to be a fight between your side and the insurance side. And yeah, ultimately, with enough tenacity, you'll prevail. But that tenacity depends on the tenacity not just of you, but of your physician. And the willingness of the physician to go to bat every time or acquiesce and say, let's take a path that does not compel me to invest that much effort into the process. So this is a good time to say, are there any questions? Opening up for discussion.
All right, Bill. So we did have one question come through the chat, so we can start with that, and then maybe we can go ahead and do your
And if
suggestion.
not, I've built in, at least another 15 minutes to talk about an ancillary aspect of Part D coverage, but I wanted to allow about 30 minutes if there's a robust discussion. So, what's the first
Sure.
question?
So the first question is, does the donut hole eliminate the need to enroll in the higher copay tier?
That's an excellent question. Here, I'm glad you asked that. All right. So, again, this is any Part D plan. And by that, I mean any Part D plan, no matter how much you've spent in premium. So the premium range for Part D plans, and in those examples I gave you for the specific patient that was taking uh, more than a dozen medications, or examples of where one of those medications was a very high-end expense. The Part D plans I was using was in a range of anywhere from $40 a month premium up to nearly $100 a month in premium. But let me expand that range even further. There are Part D plans that cost less than $10 a month. There are a lot of Part D plans that cost less than $20 a month. In fact, the norm for those plans was intended for, well, I'm not taking any meds, but I'm going to get a plan so I don't get penalized. Or I take meds, but they're all generic. I really don't need a Part D coverage if I'm going to spend retail $1 or $2 to get these meds. Why do I want to get something on top of that, even if it reduces the copayment to nothing or next to nothing? And for the first decade of Part D plan's existence, the average premium, the typical premium, was $20, $30, $50 a month. And again, people chafed at that. It's like, I'm really just doing it to avoid a penalty. I'm shelling out $30 or $40 to avoid a penalty. And no matter how well it assists in accessing my generics, I could still save money by not paying a premium and just buying them at retail. And so to fill that void, within the last decade, a set of boutique Part D products popped up. And they said, look, intended for individuals who are just doing this to avoid the penalty or just in case I just need some coverage, we'll offer a Part D plan for $7 a month. It's like, come on, $7, you can avoid a penalty. And you know what? Just to make it even more enticing, any generics you're taking, your copay is $0. So there. If you're taking 2 or 3 or 6 or 7 generic meds, you make your $7 premium back in the buck or two that you save. If, on the other hand, you're taking an expensive medication, we're not going to be so great about that. We certainly are going to impose a $480 deductible. And we'll cover it about 70, 30%, not as good as 75, 25, but still it's reasonably good. But then again, we're designed for something else. But what they didn't realize is they created a product that could work just as well as on the other end of the spectrum. Because there are Part D plans that one can purchase for more than $200 a month. Certainly a significant handful over $100 a month. But here's what happens. If you're taking even just one expensive medication, the one that's going to put you into the donut hole much sooner than later, certainly use the example of one oral cancer treatment that is going to gobble up every one of these layers in the first month. So if you had a $7 plan, well, you're going to have a $480 deductible eaten up in the first month's purchase. And once you've paid off the deductible, we'll split it at not as good as this, but we'll do it at 70-30. It's going to get eaten up in the first month. That 70-30, that 75-25, that 95-5, whatever you promise, it's only as good until we hit that number, 4,430. And then from that point till the end of the year, everything is dictated by the rules of Center for Medicare and Medicaid Service, by the rules by which all Part D plans operate. Any promises, any unique characteristics gained by spending a lot more in premium or sacrificed in spending a lot less in premium only exist until you hit 4,430. After that, you're in the donut hole. After that, the insurance company is offline no matter what you spent in premium. The government steps in regardless of what you've been spending in premium. And as long as the drug is covered, that's all you have to worry about. Is this drug on the formulary? Yes, it is. Then once you've gone into the donut hole, the feds step in and pay absolute 75% of it. You pay an absolute 25%. And then once you reach $7,050 into catastrophic coverage, you go. Absolutely, no matter what the plan promised prior to the donut hole, they're required to pay 95% of the cost, and you pay only 5% of the cost. That applies whether you only spent $7 a month in premium or you spent $7,000 a month in premium. Whatever the premium is, it only creates a unique circumstance as long as you are in the partial coverage circumstance, or helps eliminate your deductible. But if you're taking a med or a combination of meds that are so expensive that's going to put you through all the stages or most of the stages within the first month or two, the value of high-end coverage is far less effective. Any old Part D plan would work. Thus, the creation of these very inexpensive products intended for a particular reason ends up having an additional value. It wasn't intended, but certainly works, of operating quite effectively for an individual that is taking such expensive drugs that within a month, they're going to pass through all of the phases to where they're looking at 95-5 split. And on top of that, it's either paying the $7 a month for the premium or the $100 or something a month for the premium. But it's still going to work the same way, regardless. Any other questions?
All right. What I'm going to go ahead and do is give folks the option, if they want to unmute themselves, to go ahead and do so. And that way we can maybe have a bit of a discussion if there are any questions.
And this is not just about Part D. You can ask any question you want about Medicare in general or healthcare in general. Be more than happy to take it. If there aren't, I'll point out a couple other things, and then we'll wrap up for the afternoon.
Had a question just come through the chat here for you. So can anything be done to reverse this cost shifting trend from insurance company to patient?
Well, I want you to understand why at the root of this. And by the way, this is not a red thing or a blue thing. It's as purple as can be. This is a trend that was occurring at the beginning of the 21st century. It continued throughout Republican administration, throughout Democrat administration. It continues right now. It is essentially based on the idea that if we shift a huge burden of the cost of healthcare directly to the government by making it be absorbed by Part A and Part B, and then refuse to fund the system to make them able to absorb those costs, by having lesser and less individuals paying the initial Medicare tax while they're working, at a government which is less inclined to be generous with the budget to fund the escalating cost of healthcare. And the federal government is compelled to look for ways in which they can shift the economic burden from them to anything else. One way is to shift as much of the burden to private insurance, enticing them to take on more and more responsibility, but also ways to shift more and more of the economic burden to the patient. Because even the private insurance companies are going to say, well, thanks for giving it to us now. And we're going to look for ways that we can shift it away from us by denying or by compelling prior authorization or step therapy. As long as we as a nation want to try to get away with this from a budgetary standpoint as cheaply as possible, as long as we try to minimize the commitment of resources to the system, and the result of that is going to be passing the responsibility back to the patient. It's inevitable. Unless we're prepared to clamp down on the cost of things. So you have two possible situations, both of which are presumably undesirable, or else they would have been implemented far earlier than this. We can impose a draconian control by which healthcare providers and insurance companies and manufacturers, particularly of prescription medications, are regulated. We don't have much of a taste for that, though. Or we could say then it's the responsibility of government to guarantee, for the whole purpose of why Medicare was created, that will make sure that the access to healthcare, particularly access to medications, is affordable for individuals and absorb more and more of the responsibility, at least for those individuals in the donut hole. The federal government has stepped up to the plate and says, all right, look, in the bad old days, you had to pay the full cost when you were in the donut hole. And we know what happened when that. People simply stopped taking their medications or took them in less frequent doses, which you may as well not take them. The efficacy is ruined. And so the compelling nature of splitting that 75-25% was done to assist individuals, particularly lower income individuals that could never afford to meet the full responsibility in the donut hole. So sometimes the federal government takes up the responsibility. But it's ironic that it was attached to a piece of legislation that a significant part of the country finds to be absolutely onerous, the Affordable Care Act, which part of the population of the country would love to see eliminated. And guess what? With that, the assistance individuals get while they're in the donut hole. We chafe at the cost of things and we rail at how entities increase the costs disproportionately. And when someone says, then either we regulate the process or we commit the resources of the nation to assisting. And it dies a quick and terrible death in the halls of politics. So yeah, there's things we can do. Chances are we'll do none of them. Chances are the trajectory of what we're looking at. And I'll give you a real good example. Last summer, a pharmaceutical manufacturer announced a medication for the treatment of dementia. It was fast-tracked through FDA. probably a little bit faster than they should have, and my 25 years in this has made some connections and friends with the Center for Medicare and Medicaid Services. And last summer, I reached out to them. And I said, is this something you guys were encouraging? They said, hell no. I said, what do you think is going to happen? I said, this is going to be an absolute train wreck. Because unlike the cancer treatment, which is for the people that are diagnosed with that form of cancer, or MS for a particular condition, this is for dementia, this is for Alzheimer's, this is for people that are in the millions that are looking for any port in the storm. And physicians were already at the point where I contacted my contacts. Physicians were already reaching out to the Centers for Medicare and Medicaid Services saying, before we start prescribing this regimen, we want to make sure we're not going to get pushback, because the cost of this medication, which can only be assigned in a clinic or a doctor's office because of the potential side effects, is going to have a price tag of $52,000. Now, are we going to have a problem with Medicare in pushing back on our prescribing these? And Medicare basically said, look, this is last summer. This was at a point where there was still a desire with the administration to try to be perceived as a positive force. And so they're up against a political conundrum. If they come down too hard on this, but at the same time, if they don't come down at all, and if they acquiesce to this, the budget allocation for the Medicare system is going to get busted real fast. One of the reasons we're seeing such a significant increase in the premium of Part B is this was going to even be much larger. They were anticipating Part B's premium for this year being in the 200s, closer to 300, to offset, among other things, inflation in general, but the potential of what this cost was. And so they resolved in the following way. They told the manufacturer, you guys put in a lot of money and a lot of effort to get this, and you thought you had it made when it passed through the FDA. Here's the deal. We are going to slow this process down. We are going to compel a resistance to the utilization of this drug to the point where you may never get your money back. Or you can work with us. First off, you're going to reduce the price. Second off, and this isn't for public consumption, but we're going to limit the access of the medication to trial only. And you will work very hard with your doctors to get them to understand that the access of this drug is going to be only for individuals on a trial basis, thus limiting the number. And finally, and more importantly, you will, and you will not piss us off on this, come up with an oral alternative version that we can shift to Part D. Do we understand each other? So within weeks of that meeting, the price dropped from $52,000 to $26,000. How interesting. And they're still making a profit. The accessibility was curtailed by having a clear conversation with the prescribing physicians on how this would be meted out. And the manufacturer is busy developing, not just them, but there's two other companies that are busy developing a orally administered alternative that utilizes the efficacy of this medication. This is how things work. Any other questions, guys?
I don't have anything else in the chat, but I did see one person. Oh, wait, here we
You
go.
got another one. Go ahead.
uh,
Go ahead.
can the state that you choose to live in have any impact on your Medicare benefits?
Yeah. Actually, I'm glad you asked that one too. You're just feeding me just the right question at the right time. In an indirect way. And since we're looking at the new norm, here's some things you can do and intend. But believe me, this is not universally applicable to everyone. For one thing, what used to be only occasional is becoming more and more. And believe me, for the high end costs, this is just not going to work. But more and more individuals are, each time they go to the pharmacy, saying to the pharmacist, could you see what the cost of this medication would be if I did it on a discounting program rather than using my Part D card, like GoodRx? Could I get the med less expensive to any degree by purchasing it using a GoodRx discount versus putting it on my Part D? And many pharmacies will say, we're just going to do that for you automatically. Well, we will always run to see whatever access programs we have would compare with your Part D coverage and get you the least expensive. Some pharmacies do automatically, some you have to ask, some it's like you're asking them to amputate one of their limbs, but it is worth considering. And you can take some ownership in that as well, just like you can take ownership in checking your Part D coverage every year. You can also check to see if there are other ways by going online and doing it. If you'd rather not, you can, one of the things our program does on a regular basis is assist individuals in accessing prescription medications as low a cost as possible. There's also manufacturer discounts, and that tends to work with higher end uh, prescriptions. Problem is, and clearly do not recommend this, they'll only discount for certain of their medications if you have no Part D coverage. And a patient will say, well, what if I just give up my Part D? Is that the only med you're taking? And keep in mind that that manufacturer's discount is often only good for a 12-month period. After that, you're on your own. You're going to be taking this med well more than 12 months. So there's some help that you can sustain yourself. The government helps, but the government does not help most individuals. So, in addition to the discounting services and the manufacturers, there are government assistance programs. One is extra help. This is for the very low income people or people on Medicaid. This is for those that the state has acknowledged as eligible for assistance because of their income and assets. Then, in this case, the extra help program, a separate program, will guarantee, if your income is below 135% of federal poverty or at least below 150%, and these are the metrics for that. This is for very low income individuals. That the individual pays zero cost for their Part D. That will be paid for by extra help. It eliminates any deductible. It eliminates most of the co-payments. In fact, for all intents and purposes, it provides those medications at no cost, even if you're in partial LIS. It eliminates the premium for the plan. It covers the cost entirely, not just 75% while you're in the donut hole, and your co-payments are pretty minimal. Whether it's full or partial extra help, you're paying even for very, 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 very expensive medications. But again, that's for individuals who have exceptionally low incomes. In Pennsylvania specifically, this is extra help is pretty much universal in all the states, but PaceNet, Pennsylvania only, and not every state has anything remotely like the PaceNet. So if you're in Pennsylvania, you're relatively lucky. If your income, again, has to be below a certain amount, you can be eligible for full PACE benefit, which no matter what the real cost of the drug is, you're going to pay no more than $9 if it's not generic, and no more than $6 if it is generic. covers the cost of your Part D coverage, eliminates the donut hole completely. But that's not where the real value of the PACE program. It's, again, those individuals have to be really low income. It's PACE net. When you take a look at the metrics here, for a single individual, their income certainly can't be that high, but a single individual can have income up to $33,500 and get significant assistance. A married couple, income up to $41,500. Income. Well, I've got $1 million in an IRA. Doesn't count. That's an asset. What's income? The stream of revenue you get monthly, weekly, annually over the course of the year. If that stays within that range for a single person or a married couple, it doesn't matter how much wealth they've accumulated. They can be eligible for the PACE-NET program. And that guarantees that no matter what the drug actually costs, they'll pay no more than $15 for a brand, or $8 if the drug's generic. And if the drug is less than $8, most generics are, even retail, they pay only what the real cost is. So never more than, but could be less. Eliminates the donut hole. Eliminates the annual deductible, although it doesn't pay your Part D premium. You have to pay that, but for that kind of benefit, it's worth it. Now, again, it's not a perfect solution. It's still for relatively lower income individuals, but certainly not impoverished individuals. And there are many individuals that have managed to create an economic stable situation for themselves that are able to survive within a range of $40,000 a year, that have the additional benefit of getting their medications at a very low cost, even if they're inherently expensive. But beyond the kind of benefits the state will provide for its citizens that are relatively lower income, from state to state, Part D plans are essentially the same. From geographic region to region, they're essentially the same. The products that are being sold, although they're not absolutely sold in every single state, but the type of product or the quality of the product is very common, very typical. And all of the Part D plans have the same model of coverage: a deductible at the beginning, a cost sharing until you hit the threshold for the donut hole. They all have a donut hole, and they all have the same numbers for the threshold and the out-of-pocket maximum. And they all have a mandate of 5 and 95. The difference really is in that little area where before you hit the donut hole, there is a sharing difference between a high-end and a low-end premium product. But that's marginal. And unless the cost of your medications assure that you're not going to hit the donut hole at any point in the year, then that variance is only of minimal value. So there is some assistance, but not for what you're thinking and not to the degree you're hoping. Any other questions we got?
While we wait to see, I actually have just a follow-up to. So can you define or better define how they determine what your income is?
Sure.
Is your income based strictly on what you get from Social Security, or is it based on what you might have socked away for retirement and so forth?
You just asked the right question for the next slide. When determining what income counts, not all, well, if you want to be safe, when you're saying, oh, my below or above, what should I count? I would say count everything. But if you want to say, it's like if I can exclude certain things, I might be able to stay within the range that I'm eligible. Here is a list. It does not absolutely portray a totally, this is every single possibility, but it is a really good, as much as I could fit onto a slide, indication of what is counted. Now, keep in mind, income is a thing that comes to you in the course of a year. It's a payout from an investment. It's the dividends or interest, or it's the capital gain realized. It's the distribution from an IRA 401. It's the stream that you're receiving. The corpus, that IRA money that's still in the IRA account, the stock that hasn't been sold yet, the value that's still invested. That's a resource or an asset. That does not count ever in this calculation, at least in this calculation for the PACE program. So income is something you're accessing in the course of the year, usually on a regular or semi-regular basis. A resource or an asset is something that you possess, you own, but it's in a dormant process. It's still in its invested mode. It's the accounts that you've accumulated your wealth, or the value of something, like a house or a car or certain kinds of property. Those are resources. And the kinds of income that are counted, this gives you an idea. Easiest way to assume it, pretty much anything that comes your way, whether it's taxable or not, is likely going to be counted in determining. But this gives you a better model. And Drew, you wanted me to send this PowerPoint to you, and I'm sure if anybody's interested in taking a look at this, you can access this. And if you don't get it from Drew, I can send this as well. This is no problem. Just let me know what you'd like. Does that help, Drew?
Yes, I think just from looking at it from a retirement perspective, and what we help customers with here at the trust company and the bank, it's important to sort of understand sometimes where that income is coming from. So,
and understanding what the amount of that income. And again, this is not to say let the tail wag the dog, but if you know that you can maintain an income level, if you're a married couple, at just under $41,500, because most of your debts are paid, the mortgage is paid off on the house, the other kinds of significant debts are all paid down. And if there is an incentive to keep your income just a little bit lower than you had planned, the incentive is what you would get in excess of $41,500 would have to go towards your medications anyway. Let me keep that money dormant a bit longer. And the value of being in PACE net is it's going to pay for those medications that I would have had to have taken money out of my IRA or 401k. Now, again, this is for a very select group of individuals that can manage to survive comfortably on a relatively lower amount. And this is not a suggestion that you impoverish yourself or reduce your source of income and reduce your quality of life just to try to save money on prescription medications. But for some people that are around that threshold anyway, it's a question of making sure that they stay under that number, especially if the benefit is to reduce the cost of their medication significantly. So it's certainly a part of the strategy, but it's not the strategy. It's simply a consideration. Any other questions, guys?
I don't believe that there is. I haven't seen any additional come through the chat, and I'm not seeing anyone unmuting themselves. So I believe we're about to the end of the questions, but that's good. We're about to the end of our time as well.
Worked out just nicely. All right, guys. Again, as I said before, on the very beginning of the presentation is the slide that has my phone number and email. If you can think of a question later, if there's issues you want to just kick around, you certainly can send me an email, and I'll certainly get back to you within a day or two. And if it's not a question I can answer quickly with an email, we'll set up an appointment that we can have a discussion about it. In the meantime, stay healthy, stay sane. See you guys later on this year.